Kia ora koutou katoa. Welcome to our latest webinar, brought to you by the University of Otago Rural Postgraduate Program and the Division of Rural Hospital Medicine. Tonight I'm privileged to be joined by Associate Professor Garry Nixon of Dunstan Hospital and Dr. Rory Miller, who is based at Thames Hospital. Garry is the Director of the Rural Postgraduate Program at the University of Otago, and Rory is his Deputy. Both Rory and Garry take a keen interest in all things cardiac and are involved in the management of many cardiac patients in the inpatient and outpatient setting. Rory is currently undertaking his PhD in the area of chest pain and the use of point-of-care troponin in the rural setting, and some of you may have contributed to his data set. Garry and Rory have joined me this evening to discuss a topic that is dear to me and an issue that we as rural doctors deal with almost on a daily basis, and that is heart failure. So heart failure is a rather huge topic, and we want to recognise that we're not going to cover it in all its depth and breadth tonight. We also want to recognise that it's not like so many areas of medicine, it's not an area that always has a clean-cut single answer, and Garry and Rory may slightly differ in the way that they manage things and approach the nuances of heart failure. This evening we're going to take a case-based approach, focusing on two real-life cases and applying management principles to them. Please feel free to add any comments and questions via the chat box, and I'll keep an eye on that. And just a reminder to keep your mics off, and also to please complete the survey at the end, and the link to that is in the chat box, and that gives you the opportunity to give your medical council number so that I can enter your CME points with the college. And I think Rory has put that link into the chat box. All things going well, we will have an intermission this evening between our two cases and be joined by Jennifer Keys, Chair of the Division of Rural Hospital Medicine. She's currently at work, but hopefully she'll be able to join us during the evening just to chat about a couple of things. So without further ado, we will plunge into things. So we're going to start by, Garry's just going to give us a brief overview of a few concepts, and then we'll move on to the first case that Rory will present. So I know, Garry, from personal experience and having worked with you, that you're not very fond of the words heart failure being written in isolation as part of someone's past medical history. And I was just wondering if you could elaborate on why simply writing heart failure is not really adequate enough in that problem list, or that as that impression.
Yeah, that's right, Matilda, as any registrar that's worked with me will probably know. And I'm particularly not keen on seeing heart failure written by itself in the past medical history or the problem list. Heart failure is a clinical syndrome, and it's not a diagnosis. And there's lots of potential causes for it. Unless you sort of actually state the underlying cardiac problem that's leading to the heart failure, then you're really not giving anybody any clues about how to best to manage it. The hassle is, though, that most of that additional information you can only get from an echo. And critically, it's the ejection fraction and knowing whether or not that's normal or whether or not it's reduced. And I mean, that's all very well to say, but I know that in a lot of rural areas in particular, getting an echo can actually be pretty tricky. But having said that, most of us do have some bedside ultrasound skills nowadays, and even having a quick look with point of care ultrasound is way better than nothing. It's possible Roy might come back a little bit later on to talk about access to echo, because I know he's been doing some work around the figures for that.
Thanks, Garry. And we're not going to spend ages delving into pathophysiology, and we may cover this a wee bit later, but could you just tell us maybe the top kind of three causes that we'd see of heart failure in New Zealand, you know, sort of the real really more common causes?
We'll probably come to it a little bit later, so that even more important is that ejection fraction and dividing your type of heart failure based around the state of the left ventricle. But the most common causes that we would see, I mean, the real standouts obviously are hypertension and ischemic heart disease. Although having said that, dilated cardiomyopathies either due to rate-related cardiomyopathies from poorly controlled atrial fibrillation or idiopathic cardiomyopathies are pretty common as well.
I think our cases tonight are really going to strive to demonstrate that importance of differentiating between the reduced ejection fraction and the preserved ejection fraction. So without further ado, Rory, we'll move on to our first case. So I think Rory's going to present a case that he encountered in Thames, and then he might throw it to Garry to offer some thoughts on how he might have managed that case.
Thanks, Matilda. Thanks, Garry. Cool. So this is a chap who presented to Thames Hospital. He was 64. He had no past medical history or no recorded past medical history. He wasn't on any medications, but he was a smoker. And he presented with sort of a marked increase of shortness of breath over the last few days. Went from kind of being able to mow the lawns and to not being able to make it to the front door in one go. And plugging a bit deeper, he had he wasn't able to lay flat and had about 4 or 5 pillow orthopnea, and he was waking up breathless overnight. Was taken to sleeping in a chair. He'd noticed that his ankles are swollen. He probably drank a box of beer a week, but denied more than that, denied recreational drugs, and didn't know of any family history of cardiac or otherwise conditions. We got an X-ray for him, which is hopefully you'll be able to see on the screen. And his blood pressure was a little low, 110/60. Respiratory rate is certainly tachypneic with a respiratory rate of 30, and slightly hypoxic on room air. And he was definitely unable to lie flat with a JVP of 5 centimeters above the sternal notch. Listening to the chest, because occasionally still do that these days. He had crackles right up to his bilateral midzones, with marked sacral and edema probably up to his knees, or even above. And some investigations, we sent some sound at him, and Matt, I think you're online, but you can keep your emails to yourself about the quality of that echo. But hopefully that little clip's playing there on the screen. And he had a raised BNP, a raised troponin. His kidneys were doing all right, and a ECG showed that he was in sinus rhythm with a broad complex QRS that resembled left bundle branch block. Professor Nixon, what do you think?
I agree with the majority, I reckon, Rory.
Yeah.
So heart failure with reduced ejection fraction. I mean, that was a pretty poor LV function on that echo that you showed us. I mean, you guess, and it's just guessing, having eyeballed it, that's probably around the sort of 15% or so. So the important cutoffs are, just to remind everybody, if the ejection fraction is more than 50%, that's heart failure with preserved ejection fraction. If it's less than 40%, heart failure with reduced ejection fraction. And then you've got this sort of new term which describes those with an ejection fraction between 40 and 50%, this heart failure with mid-range ejection fraction, which nobody really entirely knows what to do with. These are the best terms. I know in the past we've used the terms diastolic and systolic heart failure, but the reality is that many patients have a combination of diastolic and systolic dysfunction, and it's actually those ejection fraction cutoffs that the big trials have been based on, and that's what evidence-based therapy is based on. So they're the best words to use. So shall I just summarize the important points as I see them from this guy? So he, as you can see, he's just quite a young man. He's only in his early 60s. He's got pretty obvious biventricular failure from that history in that chest X-ray. You'd be suspicious that this is on the basis of unrecognized coronary artery disease, from what Rory's told us about the point of care ultrasound. But having said that, there's generalists, we're pretty good at eyeballing and making an assessment of LV function when we look at point of care ultrasound, but we're pretty poor when it comes to our accuracy in deciding whether or not someone's got a regional wall abnormality, and like really especially in the sort of patient who's got a good going bundle branch block. So I probably wouldn't read that too much into that, which means then you've got all those other potential causes of a dilated cardiomyopathy like alcohol, rate control, infiltrative causes, post-viral, those sorts of things. The other bits of information that we've been given, I wouldn't take any notice at all of the troponin. This degree of heart failure invariably results in a bit of troponin release. And this is not due to ischemia. This is due to chronic changes that occur in the myocytes due to strain. So this will be classified as non-ischemic myocardial injury and gives you no useful information about whether or not this patient's got an ischemic cause for their cardiomyopathy. The blood pressure is not fantastic, but it's reasonable. And he's got a good creatinine, so I would describe him as wet and warm. Now, I won't go into it at the moment, but we can come back to it later if you want, Matilda. But this idea of dividing your patients up into one of those 4 quadrants based on their perfusion and their volume status is a really good way about thinking about all your heart failure patients. Some point, he's going to need a formal echo, but we can wait for that. We've got then the information we need at the moment to get on and start that initial treatment. And probably at some point down this track, he also needs an angiogram if we're thinking about a potential coronary artery disease cause for his cardiomyopathy. But that's definitely not urgent. That can get done as an outpatient in weeks or a month or 2 down the track.
Yeah, I agree with all that, Garry, and it's certainly what we were kind of thinking. So where are you going to start treating this guy?
Okay. Oh, I mean, the first job is your obvious one. It's around offloading some volume. He's got good creatinine and he's furosemide naive. So I don't think you need to sort of be too radical with that at the start. But he is really edematous, and it's pretty unlikely he's going to absorb anything orally. So I'd go for IV furosemide. But I would just start pretty gentle, just 40 milligrams and see what sort of response you get. And then you're going to continue that over the next few days. You could have a lot of weight to lose. And my rule of thumb is aiming for 1 to 2 kilograms a day.
And apart from weight, how are you monitoring your diuresis?
Again, probably anyone that's worked with me knows what I'm going to say here. The JVP is by far the most important examination, probably in all of medicine. And so that's going to be your absolute critical thing, and you're going to have a good look at that every day. And I mean, I know that it's a bit of a fag, and sometimes can be difficult to do, but it is absolutely essential. Although once again, if you're having trouble doing it, then you've always got that fallback nowadays. If you've got an ultrasound machine around, of having a look at the JVP with ultrasound, or looking at the IVC. You mentioned weight, and that's absolutely critical on a daily basis. My experience, fluid balances are pretty hopeless. They might be useful on the first day or so on the output side, just to make sure they're PUing, but overall they're very poorly done and hard to read much into. There's a bit of a vogue for repeated Bnps to monitor the severity of the heart failure and your ongoing treatment, but there's not a lot of evidence for this, and it's a rather expensive test. I think at the moment, in our setting anyway, we should continue to look at BNP as a diagnostic tool, not as a monitoring tool. I got one question for you to throw back at you, Rory, just because it's done variably in our workplace, and that's whether or not you would fluid restrict this patient as well as use diuretics.
I don't, as a general rule. There's little evidence for fluid restriction, although that's comparing 800 milliliters to 1.5 liters, I kind of just take a history on how much they're drinking, and very few people drink lots. I tell people to drink when they're thirsty, don't push fluids, but otherwise I don't make strict recommendations. Is that what you do, Garry, or do you make people thirsty?
No, I think you're exactly right. I think it just makes people feel miserable, and there's actually a little bit of evidence that we might be doing a bit of harm by applying strict fluid restrictions.
Yeah, so I mean, I think in this case I was a bit more aggressive with my diuresis. I think we gave him maybe 120 milligrams of furosemide in the first 36 hours of or so of his admission, and he lost nearly 6 kgs of fluid. But yeah, so I mean, we've got him to lose some weight. He's ready to go home, right? That's all we need to do.
No, even before you've lost all your weight, then that's the really important stuff nowadays, and the really interesting stuff as well. So I mean, there were probably a few others out there, but who can remember that the days in which we tended to think of heart failure as being diagnosis of heart failure being sort of inevitable decline, and that any patient given that diagnosis was almost invariably going to die within the next 5 years. But that's radically changed. It's probably one of the biggest therapeutic changes that I've seen in my career. And now we have this magic cocktail of drugs that, if it's done properly, and it's not easy to do properly, can decrease mortality over the next 1 to 3 years by as much as 50 to 60%. And that cocktail is that combination of ACE inhibitors, beta blockers, and spironolactone.
Well, thanks very much, Garry. So I think we'll work through those groups of drugs each individually with regard to some of the kind of particular features of each of them. But just to recap, so this is a chap who falls into that category of a reduced ejection fraction, and that's who these drugs apply to. The mortality benefit is for those with reduced ejection fraction. This guy, we need to look for a cause of his reduced ejection fraction, and we were talking about things like ischemic heart disease, that it may be post-viral. For those of us who see large amounts of methamphetamine in the community, these are the kind of patients who fall into that category as well. And then you and Rory have discussed the importance of offloading that extra fluid he's carrying, and the need to use intravenous furosemide in those early days because the absorption's so poor, and that there's no sort of one fixed dose. It's you've kind of got to tailor it to the patient, and really looking at the clinical signs and the weight of the key things, and probably not fluid restricting them. So Garry, if we first of all just start with the beta blockers. And
so I think beta blockers are a good one to start with, probably because they're the ones that they're the agents that actually probably have the greatest mortality benefit, and are probably the most important, which again is really different to what we were told when I was a house surgeon. I agree with everybody else that bisoprolol, carvedilol, or metoprolol are all reasonable choices. It's not a class effect, but those 3 drugs have got a proven role in heart failure, whereas the other 2 beta blockers on Matilda's list don't. But probably I would just differ with the majority in terms of the one that I would reach for first. Although, like I say, any one of them would be fine. I mean, my first preference would probably be carvedilol. It's got some theoretical advantages in heart failure, mainly because it's got a better alpha blockade and is a vasodilator in a way that metoprolol and bisoprolol aren't. And there has been one head-to-head trial comparing metoprolol and carvedilol, and although some people criticise the trial, carvedilol did come out a bit better. The favourite was bisoprolol, and it is the most cardioselective and probably has the fewest side effects, especially if we're thinking about asthmatics and CNS side effects and that sort of thing. But the real advantage in bisoprolol may actually be the numbers. well, it's way easier psychologically for both the patient and ourselves to get somebody up onto 10 milligrams of bisoprolol as their target than 190 milligrams of metoprolol, which is the target for metoprolol. So for that reason alone, it may be advantageous. I mean, we've got to be careful about metoprolol. The 23.75 milligram dose of metoprolol is barely much more than placebo, in all honesty, and it should only ever be used as a very small sort of starting dose or stepping stone for the very fragile elderly. The next question was about when to start it, wasn't it? And again, I think this is changing. Initially, there was this real nervousness about beta blockers, and we really wanted to get patients pretty much euvolemic and pretty stable before we considered starting it. And then there was this evidence come along that said, well, if you don't get in there and don't get the beta blocker started while they're still in hospital, then they're not actually going to do as well down the track. So I think we're much more confident about getting it started than we used to be. And if this patient was doing well and they were diuresing nicely, then I'd get them started on it pretty soon, and well before they had lost their entire 10 kilograms or whatever that they needed to lose before they got euvolemic. You could quite rationally start the beta blocker before you started the ACE inhibitor. I think most of us would still do it the other way. But as soon as I had them on a milligram or so of cilazapril, and we were day sort of 3 and they had lost sort of 4 kilograms or so and had a reasonable blood pressure and were looking pretty good, then I'd probably jump in there with my carvedilol at that stage.
Cool, thanks, Gary. And as far as you said that metoprolol, that 23.75 is a really low dose, and you are heading towards a target. What kind of target are you aiming for? How do you know when when enough's enough?
When you've got to your target, and we'll talk about that a little bit later, I guess. But you really got to be aiming for a target. You're not treating symptoms. You're seeking a mortality advantage, and your target needs to be metoprolol 190 or bisoprolol 10 or carvedilol 25 BD.
Cool, thanks. And we'll talk a bit more about the up-titrating as we go on. So, Rory, do you want to comment a bit about ACE inhibitors and ARBs?
Yeah, so the majority of the benefit from evidence-based therapy is in beta blockers and ACE inhibitors, and by themselves, ACE inhibitors or angiotensin receptor blockers contribute about an 8% absolute decrease in mortality, which is similar to beta blockers, and practically I started just before or about the same time as starting the beta blocker. As opposed to beta blockers, it's a class effect, and most guidelines will recommend start trying an ACE inhibitor, and if they're not tolerating that, then move on to an ARB. And generally start at low doses, and so cilazapril 0.5, quinapril 2.5 perhaps, and I like to try and get 1 or 2 dose increases in while they're an inpatient, depending on what their blood pressure is up to, and of course their renal function. Watching out for that, symptomatic hypotension and a greater than 30% change in their GFR and hyperkalemia over 5.5.
And how long do you think you need to keep monitoring that potassium? Is that just while they're in hospital, or do you think that you need to continue that post-discharge?
Post-discharge, I think it's like treating anyone with an ACE inhibitor, really. I mean, we should be checking a couple of weeks after every dose increase. Yep.
And I think that's really important, just reminding ourselves that it's to tolerate that slight apparent worsening of the renal function, and in fact, that's the ACE doing its job. So back to you, Gary. Moving back to the spironolactone
Yeah, thanks, Matilda. And yet your aldosterone blockers, they're sort of like your third pillar of this neurohormonal blockade that we're aiming for. So I tend to think of it as really essentially just protecting the heart from messages coming from these nasty kidneys, which are essentially just flogging it to death, really. And just protecting it from those messages and giving it an opportunity to heal. So that's why we're using the spironolactone as an aldosterone blocker for cardiac remodeling. We're not using it as a diuretic, so it's important to remember that. In fact, the doses that we're using, sort of 12.5, 25, maybe up to 50 milligrams a day, they really have a pretty small diuretic effect. Again, there's a bit of variability about when to start it, and I'm probably a bit more aggressive than what the guidelines strictly say. If you just stuck to the guidelines, then you would wait till they're well established on your ACE inhibitor and your beta blocker, and if they're still symptomatic with a GFR of less than 40, then with a ejection fraction less than 40, then you'd be jumping in at that stage. But like I really make a bit of an effort to try and get this patient started on a little bit of spironolactone before they leave hospital. And certainly this patient of Rory's, I'd be aiming to do that. I am probably pretty cautious about the dose that I'd use, particularly if they've got a degree of renal impairment. And if sort of their GFRs, between 30 and 50, then I'd only be starting them perhaps on 12.5 milligrams every second day, and then increasing it after a week or so. If their GFR is less than 30, then I probably wouldn't use it at all. And this, Matilda, is when it does become really, really important to keep a very close eye on your potassium, because it's when you're combining your ACE inhibitor and your spironolactone that you're going to get into problems that way. And I got a pretty strict regime of measuring at least twice a week for the first couple of weeks, and then probably weekly for a month, and then monthly for 3 months, and then 3 months, every 3 months after that. I think it's a couple of really important things to make sure you tell your patient when you start them on spironolactone. The first thing is they need to know is that if they become unwell, particularly if they've got a volume depleting illness, for example, with diarrhea or vomiting, then they need to stop it. So if they go home with blister packs, then somehow someone's got to be able to teach them to be able to identify the spironolactone and take it out when they become unwell. The patients we get readmitted are invariably the ones who just push on with it when they start to feel crook because they think they still need to carry on with all their tablets. And then the other important thing to warn guys for, because they may not raise it otherwise if it happens, is around the potential side effect of gynecomastia. And especially nowadays, I guess, since we've got that other option of changing them to a pleuronone if they get that.
Garry, is that on special authority still?
My understanding it is, I think, on special authority, but I think any of us can apply for it.
Cool. There's a few questions from down south. So first being, if you don't have heaps of blood pressure to play with, are you better to go with bisoprolol over carvedilol to avoid that alpha blockade?
Yeah, I can see the logic of that.
Yep.
That makes sense. But probably in reality, that's not what I would do. I would just tend to be a bit more gentle with the carvedilol and just hold things for a while, even back off very slightly, and then push on a bit further into the future. But theoretically, that's correct.
I think the next question is alluding perhaps to maybe the patient with atrial fibrillation, the tachycardic patient. Should you be pushing the beta blocker even earlier in their management?
Yeah, because that may be the cause of the cardiomyopathy in the first place. Yeah, because you get that classic chicken and egg thing, don't you? You don't know whether or not this patient has gone into atrial fibrillation because they've got a poor left ventricle, or you don't know whether or not they've got a poor left ventricle because they've got poorly controlled atrial fibrillation, and only time will tell. But if it is the latter, then, and you provide really good rate control, then you'll get a dramatic improvement in their LV function. So no, exactly right. In that situation, really good rate control and jumping in straight away with your beta blocker.
Yep.
And I must say, in that situation, I would use bisoprolol because it's probably more cardioselective and it's probably a better rate control than carvedilol.
Yep. And Matt's made the point that, you know, in using spironolactone, which is potassium sparing, that might counteract some of the effects of your high dose furosemide while they're in hospital.
Yeah, that's right. Yep, and I know Matt's a proponent of that, but he's exactly right. It might make that a bit easier, and you may not spend, you know, every afternoon charting large doses or clorvescent if you do that.
So those are really our key three things: our beta blocker, our ACE inhibitor, and our aldosterone blockers. But there's certainly some new therapies on the horizon, and not just medical therapies. So I'm just wondering if you want to comment a bit to that, Rory.
Yeah, sure. I think I'll just reiterate again that the three drugs or three classes of medications that we've talked about are the three pillars of long-term, short, medium, and long-term heart failure treatment, and with reduced ejection fraction. And audit and registry data shows that the reality is that that's not. People are discharged from hospital with following an admission with heart failure after just having some furosemide and not being commenced or have those doses increased if they're already on them. So I think that's just the key backbone for treating heart failure. But we've got a sexy new drug called Intresto, which is a angiotensin receptor neprilysin inhibitor that's still on special authority, and that's a replacement for your ACE inhibitor or ARB. It's commenced after a 36-hour stand down. It's a twice-a-day medication, and again, you tend to start it at the low dose and move up every 2 weeks or so. The special authority for New Zealand is that you need to have a diagnosis of heart failure. You need to have class 2 to 4 symptoms. So at worst or at best, being short of breath doing sort of activities of daily living, and class 4 being short of breath all the time, including at rest. Despite the studies showing that it's beneficial for those with ejection fractions less than 40% in New Zealand, you need to have equal to or less than 35% as your ejection fraction. However, there is a clause now on the special authority that if an echo is not reasonably practical, and in the opinion of the treating practitioner, the patient would benefit from that treatment, you can still hand on heart fill out that special authority, and the Pharmac has sort of said that, you know, COVID's the only reason why you can't get an echo, so that's why that clause is in there. You're right. So we in Waikato, we would start this medication once people are on pretty good doses of ACE inhibitors and beta blockers, and we're not so concerned about their spironolactone dose before starting. And I mean, anecdotally, I've seen some really, really good response to people who have been struggling with their heart failure, started Intresto and had some pretty big turnaround in terms of their symptoms. Not sure what your experience is, Garry.
I think the reason we got you to talk about that one, Rory, is because your experience with it is good and mine's not quite so good. But I think the problem, my experience with it is that we've come to it pretty late, and we've tended to give it to people when we're running out of other options a bit, and they've got pretty sluggish blood pressure and stuff, and we've ended up really dropping their blood pressure through their boots when we've tried it. But I can imagine that more and more we'll be doing what you guys are doing up in the Waikato and jumping in with it quite a lot earlier, because there is great evidence for it.
Thanks, Roy. And I noted when you were presenting that case, so that chap has a left bundle branch block. So would he be a candidate for resynchronization pacemaker? and maybe just giving a little bit of background to that therapy.
So I think that was one too. So yeah, I think this is a good one just to keep in the back of your mind. It's not going to happen all that often, but it's one of the few situations when there's real value in the patient going back to see the cardiologist. They can offer something which is genuinely going to make a difference over and above what you can do. So if this guy comes back after 3 months, over that time you manage to get him on to reasonably good evidence-based therapy, but despite your best efforts, he's still pretty symptomatic, and he's still got an ejection fraction less than 35% with this really quite broad left bundle branch block, then it is worth asking the cardiologists if they would consider him for a resynchronization pacemaker. And my experience of seeing patients with those is that they do make a big difference, and patients have done very well. Is that yours, Rory?
Yep, absolutely. As long as you get their native heart rate low enough that the pacemaker is doing the job, and they're in sinus rhythm. I think atrial fibrillation is a little more controversial about whether it is effective or not. But definitely for those in sinus rhythm with broad complex QRS, so greater than 150 for non-left bundle branch block, and greater than 130 if they do have left bundle branch block. Yeah, absolutely.
So there's some other aspects of long-term management that we might just skip over in the interest of time, but I'll include in the show notes, and we could always come back to if things are going well. So kind of thinking more towards the point at which you've reached your euvolemia, and they're feeling amazing, really keen to get home, and heading home with a bit of furosemide and small doses of ACE inhibitor and their ARB and their Spiro, and they think that they're cured and the job is done. But is it? Where to from here at that point of discharge? And I'll just give you a little bit, Garry. There's a question in the chat box which I'm sure you'll cover here, and that's around, if you are sending them home on furosemide, how do we reduce that dose? What's the long-term approach to the prescribing of furosemide in this case?
Yeah, thanks, Matilda. That's a really good point about the furosemide, and that's definitely something that we need to cover. I'm probably going to get Rory to cover that one, but this is a really critical time. And it's really important that, both the person that you're handing their care over to, if it's not yourself at the point of discharge, and the patient understand what's got to happen over the next 3 months. And it's really important that the patient's on board about what you're trying to achieve. They need to understand that this next 3 months or so is not about symptom control. It's about the healing of the heart. And we're aiming now through this next period to get them onto a drug regime, which is going to really increase your chances of being alive in the current years. And it's not going to be painless. It's probably going to hurt. So I mean, I liken it to sort of like, the chemotherapy of cardiology. So what you're going to do with them as an outpatient over the next 3 months is they're going to come along, they're going to be feeling pretty good, and then you're going to increase the doses of one or both of your evidence-based therapies. And as a consequence of that, they're going to be fatigued. They're probably going to have some postural symptoms with their blood pressure, and not particularly enjoy it. But slowly over the next couple of weeks, those symptoms will ease off and they'll come right, and they'll come back and see you. And when they do, you're going to hit them again with another dose increase, and they're going to feel pretty lousy again for probably a week or so. But if they don't understand this and why you're doing it and the importance of it, then it won't happen. And we know from studies that have been done that actually we do a really poor job of this titration period, and heart failure nurses do a much better job of it. In all honesty, I guess the other analogy I use is sort of, which a lot of my patients understand, is around sort of like a two-stroke engine. We can send them away on a pretty rich mixture and a nice high blood pressure, and they'll feel pretty good, but they're going to burn it out pretty damn quick. And we've got to send them away on a pretty lean mixture if we want it to last into the long term. What sort of blood pressure do you put up with these patients? Well, I mean, if they can get up and walk into the consulting room, then probably the blood pressure is good enough. And the worst thing we should be doing, unless they're very symptomatic, is easing back on that on the dosage of those medications, because we measure a lowish blood pressure. And the same goes to accepting, moderate rises in creatinine as well. We'll come back to the furosemide in a minute, shall we, Rory? But Matilda, we're going to sort of cover off that one question. I mean, I do realise, having said that sometimes you're just stuck. Sometimes you're just going to not get to the target doses of all your medications. And you're going to perhaps get to move up on one more dose of something, but you've got to make a bit of a choice. Which one are you going to go for?
So I guess we could take that moment, Garry, to do that last poll, which is the third question. So just bringing that up, just remember, you just to submit your answer, you just need to flick a answer for the other two questions again. We'll just give that 30 seconds or so. So blood pressure 105 on 70, heart rate 70. Those are your current medications: Cilazapril 1, bisoprolol 6.25, and Spironolactone 12.5. You're seeing them in your clinic down the track, and you feel like you're remembering Garry's voice in the back of your mind that you need to up-titrate. What can you push up in this situation?
I think probably we mean Carvedilol 6.25 rather than bisoprolol, don't we?
Whoops, sorry.
Or it could be bisoprolol 1.25. It doesn't matter.
Uh, 80% have voted there, Matilda. So bisoprolol was the winner, 63%, 35% chose Cilazapril, and 1 person chose Spironolactone. It's all right, we don't know who.
Yep, so I'm with the beta blocker group. I'm with the bisoprolol group. If you've only got so much more blood pressure to spend, you're probably going to get best bang for your buck spending it on your beta blocker. So that's probably what I would go for. Hey, Rory, someone's asked about furosemide, and managing the diuretic is really important part of allowing you to up-titrate these medications. I mean, I know you think this is important as me, so I'll get you to cover that if you want.
Yeah, so when people go home from hospital, I give them a table about how to manage their furosemide going at home, and I spend quite a lot of time going through this. So I encourage them, if they don't already, to definitely get some scales and work out that if their weight's going down, then they reduce their furosemide dose, and if it's going up, they increase their furosemide dose. And preference is to try and down titrate it as much as you can. There's no mortality benefit for being on furosemide, just symptoms. Yeah, and I guess in our region we're blessed with some really good heart failure nurses, or one heart failure nurse who will get around and also reinforce this and also up titrate their other medications. And sometimes, so recommending the lowest dose to keep them at their dry weight and their dry weight, and sometimes that's even being off the furosemide altogether. But I guess the other point to make on this is that if you see someone coming back and maybe their creatinine's gone off a bit and their blood pressure's down a bit, is to not just blame the ACE inhibitor or the spironolactone or the beta blocker. Have a look at their diuretics, and they might just be running dry, and you may be able to decrease their furosemide, and that will give you room in either their renal function or their blood pressure to up titrate the evidence, the stuff that's going to stop them coming back to hospital and keep them alive a bit longer.
And further to that sort of discussion around furosemide, we're all faced with a patient who's not really responding to their furosemide. So in the other direction, you haven't been able to get them off it. In fact, their weight seems to be going up despite the increasing doses that you're prescribing them. Could you just comment on maybe some tips and tricks on how you might get around that situation?
Yeah, so often when everything's real wet and soggy, their guts are real wet and soggy, and furosemide isn't as well absorbed. Bumetanide, which is another loop diuretic, so 1 milligram is worth 40 milligrams of furosemide, is supposed to be a bit better absorbed across an edematous gut. So that might be something that if you can switch them over to bumetanide, might keep them out of hospital. Sometimes you need just to bring them in and give them IVs. If IV and to I don't know, Gary, what you do, but I generally start with just convert their oral dose to an IV dose to start with to start a good diuresis. And some people are really stubborn, so you can, and if they're still not weeing despite really strong doses of furosemide, then you can add a thiazide or spironolactone, but you need to watch for hypotension for that, and that can be anything from sort of chlorthalidone, bentrafluozide through to metolazone in terms of your thiazide.
Sorry, Roy,
yeah,
do you mean adding them as to the furosemide, so using
to
those...
the furosemide? Yep. So,
and just you can often just do that temporarily, right?
Yep. So I would give my strategy would be to give some a single dose of thiazide right as a once only, and see what happens. You could also add in vaso/venodilator like GTN as an infusion to your furosemide to help aid the diuresis. All of these will be trade-offs with hypotension. And I guess the other thing that comes up is whether to use furosemide infusion versus furosemide IV boluses. And I must say that the evidence is really mixed, and it really depends what and when you read the studies and meta-analysis, but probably there's no evidence that infusions are any better than boluses, and they may even worsen. There's some studies that show that they worsen acute kidney injury, rehospitalization, and there's a mortality effect associated with being on an infusion rather than boluses.
Rory, do you have a comment to make about the frequency of furosemide IV dosing or oral in hospital, and what time of the day it should be given? Do you think that matters?
I really don't think it matters. I mean, no, having said that, it depends. It depends on the mobility of the patient and how much nursing resource it takes to get that patient to pee. I think generally I still stick to morning and lunchtime.
Yep.
But in the emergency departments, if someone's very puffed and they're really wet, then I'll just chut it. Gary, do you have any thoughts on that?
No, I think that's covered it pretty well. I'm like you, I would only tend to add thiazide as a once-off initially. If you're going to use it regularly, they only might need it sort of a couple of days a week or something like that. You can often get quite a profound diuresis with it when you're adding it to high doses of furosemide, and you will get quite marked azotemia as well with it pretty frequently. So you do have to watch them. But this is sort of last ditch sort of stuff, really, isn't it? It's when you're in trouble. Yeah, and I know what you say about furosemide infusions, but when absolutely nothing else is working, then I occasionally resort to it. Do you as well, Roy? Do you? Yeah.
And I think, Gary, there may have been one other drug that you might have wanted to promote. No, suggest.
Yeah, well, if Roy gets to sort of like mention Intresto, sort of like from the 2020, then I get to mention digoxin. It's only fair, really. So I know it's pretty old-fashioned, but if absolutely nothing else is working, then it's still worth just a little bit of dig. You're not going to get a mortality benefit from it, but there is evidence that you will reduce hospitalizations and improve symptoms. And let's face it, in these particular patients, that's what you're aiming for. If you do just decide to add it in, then I'd stick with a pretty small dose. Most of the problems with digoxin occur at higher blood levels in terms of arrhythmias, and most of the benefits at lower blood levels. So most patients wouldn't get any more than a little PG a day, and you'd be aiming for a drug levels around the 0.5 to 0.9, which is quite a lot lower than most of our laboratories report the target therapeutic range.
I was just wondering your thoughts, just going back to the importance of that reduced ejection fractions. A few times I've noted patients who've had reduced ejection fractions on an echo, say post a non-STEMI. So they hadn't necessarily presented in heart failure, they'd just gone on to have an echo, and they didn't really have any signs or symptoms of heart failure, but certainly that was noted that their ejection fraction was down. What approach do you take? Do they earn themselves some cardiac chemotherapy as well?
Yeah, these are really important patients, and we know for some work that Rory's done, that Rory, these, while just about all STEMI, non-STEMI patients really should have an echo as part of the index admission, particularly those from rural areas, even though they're getting the angiography in the big hospital as well, are less likely to actually get an echo. And I mean, I think that's a real problem, because they're also less likely to get it at follow-up when they go back to their rural community, because the service is less likely to be available locally. But we should really be working hard to pick these patients, because even though they're totally asymptomatic, we know that if we get them onto a beta blocker and an ACE inhibitor, then they're much less likely to run into trouble with a failing ventricle down the track. So reality is you probably should have the same target doses, but in actual day-to-day practice, I don't think most of us push them as aggressively as you would the patients with symptomatic heart failure.
Yep, sure. So Rory, moving back to the patient who we've discussed this chat with, the new diagnosis of heart failure, shown to have reduced ejection fraction, followed all evidence-based therapy in hospital and as an outpatient, established on high doses with an excellent response. You review him in clinic in a year's time, let's say, and he has a repeat formal echo. His ejection fraction now is 58%, so well within normal limits. Are you happy to start down titrating, or perhaps even stopping some of his medications and send him on his way?
I would try my hardest to keep this guy on everything that he's been on that's made him better, and I think there's a real risk fall backwards if he stops his evidence-based therapy. I might make some concessions around spironolactone, but that's probably the only one, and really try and keep him on an ACE inhibitor and a beta blocker in particular, and warn him that this is, currently this is likely a lifelong, or at least as long as he can tolerate medications for him. Some exceptions might be where there's a completely reversible cause for their reduced, something like peripartum cardiomyopathy, thyroid that's now been totally treated, alcohol, or what we are seeing more and more of is meth-induced cardiomyopathy. You might be a little less firm in your advice, but in general, try and keep them on for as long as you can.
Cool, thanks guys. Well, that kind of brings us to the end of our case that illustrated our heart failure with reduced ejection fraction. Our second case, unsurprisingly, is going to be one with a preserved ejection fraction, and is a much shorter case, and we'll see why when that comes to therapy. And before we move on to the next case, Garry, I think I'll just touch on this question that has come from the Cook Islands, because I think it's really important and relates back to one of those causes of heart failure with a reduced ejection fraction. So, you know, the elderly patient with heart failure and AF, whose heart rate's say 130, blood pressure 98 on 62, this clinician's feeling a little bit nervous about starting beta blocker and wondering about a different agent. You know, should they be using DIG or amiodarone? What do you think about using a beta blocker in that kind of setting?
There's a recent trial which looked at digoxin in these patients. A smallest trial, which there's been some preliminary data come out of, which is suggesting that we've probably undervalued DIG in recent times for these patients. So if you've got a pretty sluggish blood pressure like that, then the first thing that I would be jumping in with would be a bit of digoxin, particularly if they're frail and elderly. And then, you know, you may actually see quite an improvement with that. And if you find then that you need to improve their exercise tolerance and get a little bit better rate control on exertion, then perhaps add in a little bit of beta blocker on top of that. But the first thing that I would be reaching for in that situation would be DIG.
Cool, thanks, Garry. Any other comments on that one, Rory?
No, I'd probably reach for DIG as well, and maybe a very small dose of beta blocker to start with that.
Cool. I'm sorry, Rory, I think the one thing that we missed from your case was kind of the conclusion of what might have been the underlying pathology that had caused his heart failure in the first place. Was there any resolution to that?
I mean, he lost quite a lot of weight really quickly, as I mentioned, and he felt heaps better. I mean, there was a bit of a wrinkle, as there always is with real life patients, and he'd also been collapsing, which was a reasonably recent thing, and we captured some VT. So he went to town and had an angiogram as an inpatient. It took nearly 2.5 weeks for that to happen. But it happened. Extensive coronary artery disease, and got some stents. His formal echo showed ejection fraction with 20 to 25% and some regional wall motion abnormalities. And he had heaps more VT when he was over in Waikato, and ended up with a CRT defibrillator.
Cool, thanks, Rory. So if we now move on to our next case.
So this case is pretty common where I work. It may be interesting
Ollie,
to know,
I'm here, buddy.
I suspect it's a bit more common down south, this sort of presentation, than it may be in the further up north. So 76-year-old lady, history of hypertension. She's noted some really non-specific shortness of breath over recent weeks and months, without any real cause being found. But she becomes very suddenly short of breath one night and ends up being admitted by ambulance at about 1 o'clock in the morning. As part of that workup for a shortness of breath, she did have an echo done, which showed moderate left ventricular hypertrophy and a moderately dilated left atrium, but a normal ejection fraction. Only medications are thiazide. And that's a chest X-ray on admission. She's in obvious respiratory distress. She's tachycardic, markedly hypertensive. JVP's up a bit, but she's got no peripheral edema, and she's got a lung fields full of creps. Her BNP's up modestly, as is her creatinine and her troponin. And her ECG, she's in sinus rhythm with left ventricular hypertrophy and strain. So you know this sort of patient, Rory, even in Thames?
We see it not uncommonly, but certainly in Dunstan. And pretty stereotypical presentation of heart failure preserved ejection fraction, and probably represents the most common of the three phenotypes that seem to be emerging from the literature. So an elderly lady with hypertension, left atrial dilatation, left ventricular hypertrophy with a normal ejection fraction. The other two being younger, particularly men, smokers, and the third group, a very sick, comorbid group who don't do very well at all. So this lady's presented obvious respiratory distress, early hours of the morning. She's hypertensive, BNP's elevated, and I think, although it seems pretty straightforward, and especially given that we're talking about heart failure tonight, it's often a bit more challenging than this. Her tachycardia strikes me also, and although she's got sinus rhythm, this presentation, I also wouldn't be surprised if it shows if she had atrial fibrillation flutter. And of course, always thinking about alternative diagnoses, which the tachycardia might spring to mind, like VTE, pneumonia, sepsis. Again, like the previous case, probably wouldn't pay much attention to that troponin, especially if she's not having any chest pain. I think that rise is very unlikely to be due to an obstructive myocardial infarction. In terms of managing this lady, I think I would start with some sublingual GTN, sitting her upright. And although she probably doesn't have a problem with too much total body fluid and it's just all in the wrong place, I probably would give her some furosemide as well. And see that and I'd probably start with 40, but her creatinine's up a bit, so may need to use more than that given her renal function. But I think after seeing how she tracks with a couple of doses of sublingual GTN, I'd probably be pretty keen to start either a patch or an infusion of GTN, depending on nursing resource and where we're at, and tolerating a systolic blood pressure anywhere above 90 for this lady.
Yeah, I agree with all that, Rory. I think that point that you made about her not being volume overloaded, that this is just fluid in the wrong place, is a really important one, and agree totally. It's all about nitrates for this lady.
Do you tend to use a patch or go straight for an infusion, Gary?
Like you, I'm pretty keen on the sublingual GTN for a start, just because you can get it going so quickly. And you can easily titrate that, a couple of puffs, a few minutes later, another couple of puffs, watching the blood pressure, because that's what you really got to do, is get that blood pressure down really quickly. But I do really like a GTN infusion, and as soon as you've got a few puffs of sublingual in, I'd be asking the nurses to get that up and going and getting to titrate that again pretty quickly, to get that PP down.
Yeah, I also think the use of CPAP in these patients is also really effective, especially for symptom control.
Rory, would you just use that for that kind of just early stage when they're sort of in acute distress while your other therapy is kicking in, do you think?
Yeah, yep. My experience is they don't need it for that long, and probably just until their blood pressure comes down and the heart is offloaded.
Is there often a triggering event for these patients, or some explanation you can give for why they might deteriorate, or does it just often just seem to kind of come out of the blue?
I reckon it comes out of the blue. I think we often sort of get hung up trying to find a cause, like, have they had an MI or something like that. But I think that's very seldom the case. I think the important thing here is the hypertension. And they just sort of wind up into this hypertensive crisis, is my assumption. So what happens is, the blood pressure goes up a bit, puts a bit of strain on the heart. There's a bit of catecholamine release, blood pressure goes up a bit further, and it just winds up into this vicious circle over quite a short period of time during the night, and then and crashing pulmonary edema. But you're actually hunting for an other cause beyond that. I think very seldom will you'll find anything.
Yeah, I agree with that. I think it's something that just tends to happen, eh?
Yep. So any other aspects kind of about their ongoing management once you've gotten through that initial crisis?
I mean, I think that you need, I mean, she needs to have her thyroid checked and magnesium, calcium, and all those kind of things. But as opposed to heart failure, reduced ejection fraction, other than treating what you see, there's not a lot of evidence to do anything else. So this lady needs good ongoing blood pressure management. I'd probably choose, I mean, you can pick whatever blood pressure lowering agent that you want. I'd probably choose an ACE inhibitor. I'd still bet that she's a lady that has or is going to get some atrial fibrillation, and an ACE inhibitor might reduce the the number and length of paroxysms for her. But also her creatinine's a bit off, and the kidneys might like the ACE inhibitor as well. But otherwise, there's some evidence that spironolactone or plenarone might help in that very comorbid cohort or phenotype of patients with heart failure, preserved ejection fractions. But there's very little evidence other than treating what you can see. So keeping good control of their hypertension or their atrial fibrillation if they're in that. Yeah, Garry, any thoughts on that?
No, I agree with that. And it doesn't take very long to cover the evidence-based therapy for the management of heart failure with preserved ejection fraction, just because pretty much there's no proven evidence-based therapy. So yeah, she is quite likely to need a little bit of a diuretic into the future, but these patients are often really pretty brittle, and it's easy to give them too much diuretics. So they probably only need quite a small amount. You need to be reasonably careful with it. It's going to be quite unlike that patient we had first up, who with a very poor LV function and who presented grossly edematous. I wonder if it's worth just touching very briefly on the diagnosis of heart failure with preserved ejection fraction, because I know that I find it really pretty problematic. It was really easy. It's pretty easy when someone presents like this, when they present in crashing left heart failure. It's pretty obvious that they're in heart failure, and they're also very hypertensive, and you've got the benefit of the echo, but it's not the case. I mean, it's frequently a lot of these patients present the way she initially presented before her admission to hospital, just with shortness of breath, for which you can really find almost no other explanation. You'd like to think that a BNP is really helpful, but it's not nearly as helpful as it is in heart failure with reduced ejection fraction. And an awful lot of these patients will have BNPs, which is sitting in that marginal grey, frustrating sort of zone. The echo is important, but again, the changes can be reasonably non-specific. I mean, I really like to see either a dilated left atrium or left ventricular hypertrophy. And if I see one of those two things, I feel much more comfortable about making the diagnosis of heart failure with preserved ejection fraction. I must admit, I find those more sort of vaguer markers of diastolic dysfunction, which modern echocardiography sort of tries to find for us, less helpful. And I think that frequently they're not actually present. And as Rory said, many of these patients in atrial fibrillation anyway, and you can't measure those measures of diastolic dysfunction anyway. So I mean, whatever, it can be quite a difficult diagnosis to make, and not infrequently it is a diagnosis of exclusion.
Well, thanks for that, Garry. I think that it's important to be aware of the difficulties around that diagnosis. Just going backwards in time, just a couple of questions. This is probably more relating to the first case, and the use of the digoxin that we discussed finally. In those sort of situations, do you need to load those patients with dig, or just start them on that low dose that you're intending to keep them on?
To me, I would generally, this is a pretty chronic sort of situation. where you're dealing with this really pretty close to end-stage heart failure, and I probably wouldn't bother to load in that situation. The situation where I'm much more likely to load is where you're trying to get more rapid control of your atrial fibrillation.
Yep. So do you think any further kind of comments from either you for the ongoing management of the heart failure with preserved ejection fraction situation, other than it being frustrating?
I think it's helpful for some of the patients to know that there is part of it, that shortness of breath on exertion that they're getting is due to not necessarily a weak, but to a stiff heart. And if it's well explained to them and they understand what's causing it, then they'll perhaps find it a little bit easier to live with.
Yeah.
I don't know.
Yeah. Any further comments to that, Rory?
No, not really. Matilda.
Cool. So that brings us to the end of our two cases. I just wonder if we could come back to each of you and perhaps just what single learning point you'd like people to carry away from this evening. And our brains can usually only cope with about one thing from a presentation. What would that be for you, Garry?
Oh, I think that's easy. That's around the up-titration of evidence-based therapy in heart failure with reduced ejection fraction. And I think it's so important, can make an enormous difference, and it's something we do really poorly.
Matilda, you're on mute there, but I think were you asking me?
Yep.
Yeah. It's the same. If someone comes into hospital with heart failure, reduced ejection fraction, start a beta blocker, an ACE inhibitor, spironolactone, and if they're already on it, then send them out on a higher dose.
Yeah, and I know there's at least one cardiac nurse in the audience, and I'd just like to give a shout out to them, and also emphasize the importance of engaging them in that process if you've got access to a nurse, that them having that input once the patient's out in the community and monitoring that up titration is really valuable. So that brings us to the end of our heart failure webinar tonight. I want to say thank you so much to Rory and Garry for all the expertise, and thank you to Garry for all he's taught me about the management of heart failure over the years. So good night to everyone. Pō marie, and ka kite anō.